Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Future ophthalmologists, what is going on here? This patient's eye has sclerokeratitis. It can be seen in patients with Wegener granulomatosis, also known as granulomatous polyangiitis. We're going to be talking about vasculitis pathology. This topic and all the other topics are covered in your book, Medical School Pathology and Step 1 Review. Vasculitis. Vasculitis is inflammation of the blood vessel wall. You know the structure of an artery wall. You remember this from cell structure and function or histology, whatever your school calls it. You have your endothelium, your tunica intima, your tunica media, your tunica externa, right? You know where the smooth muscle is. You know where the elastic membrane is. You even know where the tunica adventitia is. You know that red blood cells carry oxygen through this vessel. There's so much that you know. The arterial wall is made of 3 layers, which include the tunica intima, the tunica media, and the adventitia. The tunica intima contains the endothelial intima. The tunica media has a lot of the smooth muscle, and the adventitia is the connective tissue, that adventitia. Most instances of vasculitis have an unknown etiology. And most instances of vasculitis are not even contagious. You don't need to wear a mask if someone has a vasculitis for the most part. You don't need to worry about it being contagious. Clinical features associated with vasculitis include fever, fatigue, myalgias, muscle pains, and even weight loss. Some vasculitides may cause organ ischemia due to thrombosis or luminal constriction of the inflammatory vessels, right? That makes sense. If the vessel is constricted or obstructed, oxygenated blood or blood with the nutrients isn't going to make it downstream to the target organs. Vasculitis is classified into 3 major groups: large vessel, medium vessel, and small vessel, and that's how we're going to approach it. The aorta and its major branches are affected by large vessel vasculitis. Muscular arteries that supply organs are involved in medium vessel vasculitis. And arterioles and capillaries and venules, those smaller ones, are involved in small vessel vasculitis. Here we can even see that vasculitis can be picked up by radiology utilizing an FDG PET CT showcasing severe vasculitis of the major vessels. And here our patient has petechiae and purpura on their lower limb due to medication-induced vasculitis. So keep that on your differential. Always have medication-induced issues on your differential. This image is showing histopathology of a particular condition associated with Cianca, which is Wegener granulomatosis. Some people remember it as Wegener granulomatosis with a C, so that they remember it's Cianca. Henoch-Schönlein purpura can affect the kidneys. And here we see IgA staining in the glomerulus of a patient with Henoch-Schönlein nephritis. Now this patient has a vasculitis that affects their tongue. This is classic strawberry tongue associated with Kawasaki disease. Now, what other critical organ is involved with Kawasaki disease that pumps blood? Right, the heart. The heart is involved with Kawasaki disease. Regarding polyarteritis nodosa, you can see a microscopic figure representation showing nodular thickened and branched arteries from the small bowel mucosa and various other nodular thickened areas. And regarding Takayasu arteritis, the blood flow pulse wave in the central retinal artery can actually be measured. You can tell that there's an issue if the laser Doppler imaging is abnormal. Here we can see a number of giant cells affecting a temporal artery. This is temporal arteritis, also known as giant cell arteritis. Do you see the giant cells? Make sure you can see them. There's at least one prominent one near the center. If you look at the center and go up about halfway to the corner in a somewhat of a 2 o'clock-ish fashion, you should be able to see it. You got it. You see the giant cells. Now here we have a micrograph showing a vasculitis involving many eosinophils, right? So eosinophilic granulomatous with polyangiitis. Now let's specifically talk about large vessel vasculitis, starting with temporal arteritis or giant cell arteritis. And the name temporal clues you in to what artery is affected, right? Temporal arteritis is a granulomatous vasculitis that typically affects branches of the carotid artery, i.e. the temporal artery. Here in this image, we have a cross-section of a temporal artery showing giant cells within the smooth muscular area, right? Classic presentation of giant cell arteritis. And this stain that's making it look somewhat blackish brown is the Elastica Van Giesen stain, also known as EVG stain. Temporal arteritis affects females more than males. And temporal arteritis usually affects individuals that are considered elderly. Symptoms of temporal arteritis classically include headaches, painful jaw. Can't chew, doc. You let them know that is jaw claudication, because you know the fancy words. You're so smart. They might even experience vision problems due to ophthalmic artery involvement, and frequent flu-like symptoms, even joint pain and muscle pain, myalgia. Lab findings of temporal arteritis include, you must know this, elevated erythrocyte sedimentation rate. Okay? Now again, do you see the giant cell? Okay. Temporal arteritis lesions are segmental, and long segments of vessels must be biopsied, reviewed by the pathologist, possibly stained. You'll get your results eventually 2 to 3 days later for the diagnosis. Temporal arteritis is not excluded by a negative biopsy result. So when the pathology report comes back, it says no giant cells appreciated. That does not exclude temporal arteritis. Now, if it came back positive, boom, hang your hat. But a negative diagnosis does not exclude it. Histologic assessment of the temporal artery of a patient with temporal arteritis classically shows an inflammatory artery wall with giant cells and intimal fibrosis. Temporal arteritis is treated with corticosteroids. And unfortunately, blindness is a potential risk of temporal arteritis, especially if it is not treated. Now let's talk about Takayasu arteritis. The aortic branch points are typically affected by granulomatous vasculitis in Takayasu arteritis. And note, in this image, we have somewhat of a dim representation, but however, it is a axial T1 weighted post-gadolinium MRI in a patient with Takayasu arteritis. And it's showing a thickened, enhanced aortic wall. I would like a radiology consult. Anywho, Takayasu arteritis is also known as pulseless disease. Because you can't hear it. You can't hear it. Takayasu arteritis is a condition that typically affects young Asian female adults. The name Takayasu might help you remember that. That's not John or Jimbo or Antoine. It's Takayasu. Symptoms of Takayasu arteritis include visual issues, neurological symptoms, or even weak or non-existent pulse in the upper extremities, right? So you might see that in a clinical vignette. Lab findings of Takayasu arteritis include elevated erythrocyte sedimentation rate. So differentiate this from giant cell arteritis. Takayasu arteritis is treated by corticosteroids. Here we have an image showcasing pathology in the chronic phase of Takayasu arteritis, showing fibrosis in all the layers of the vessel wall and markedly thickened intima. And this is in a child. Here we see the left main coronary arterial narrowing in a 16-year-old female with Takayasu arteritis. Do you think she would have presented with pulseless disease? Let's move on to medium vessel vasculitis, starting with polyarteritis nodosa. Polyarteritis nodosa is a multisystemic disorder characterized by widespread inflammation, small and medium vessel damage. Organs commonly involved by polyarteritis nodosa include the skeletal muscles, nervous system, gastrointestinal system, kidneys, right? As we can see here, the glomeruli. Polyarteritis can be associated with acute interstitial nephritis. And even the cardiovascular system can be involved by polyarteritis nodosa. The lungs are typically spared in polyarteritis nodosa, right? Now, symptoms of polyarteritis nodosa include hypertension due to involvement of the renal arteries, right? Stomach pain and melena due to involvement of the mesenteric vessels, neurologic abnormalities, and even skin lesions. Keep in mind that polyarteritis nodosa is associated with serum HBsAg, hepatitis B surface antigen. The histopathology of polyarteritis nodosa shows transmural inflammation and fibrinoid necrosis, like what we can see here in these images. Fibrosis may present later on as a classic buzzword, string of pearls appearance on imaging. Polyarteritis nodosa is treated with corticosteroids and cyclophosphamide. Note, polyarteritis nodosa is lethal if not treated. Here in this image, we can see various necrotizing cutaneous lesions due to polyarteritis nodosa. Let's move on to Kawasaki disease. What's the buzzword for this tongue? Strawberry, right? Kawasaki disease causes vascular inflammation of medium-sized vessels. Kawasaki disease typically affects children of Asian descent. Kawasaki, right? Another easy way to remember the nationalities or ethnicities for these conditions, right? Use your mnemonics when you can. They come in handy. Symptoms of Kawasaki disease include fever, conjunctivitis, palmar rash. Look out for that on physical exam, right? Rash on the soles even. And lymphadenopathy. In Kawasaki disease, the coronary artery is usually involved and increases the risk of myocardial infarction with thrombosis and aneurysm rupture. Kawasaki disease is treated by aspirin and IVIG. And note, most children with Kawasaki disease completely recover. Isn't that fantastic? Here we see angiography showing ectatic LAD with a largest aneurysm equaling 6.5 millimeters. LAD is short for left anterior descending artery associated with the heart, right? Remember the clinical symptoms for Kawasaki disease. You see these signs. You see that palmar rash. You see the strawberry tongue, right? Keep a lookout for that. This is what you don't want to see. You don't want these patients to have an autopsy. We want to keep them alive, right? Treat them appropriately. Hopefully we can avoid a myocardial infarction in a 7-year-old, right? Let's move on to Buerger's disease. Now immediately, I hope your eyes recognize that the third digit is missing its distal portion. Buerger's disease is a type of vasculitis that causes necrosis of the fingers and toes. Here we have thromboangiitis obliterans, right? Which is just another name for Buerger's disease. Buerger's disease. Symptoms of Buerger's disease include autoamputation of the digits, usually the fingers and or toes. And I'm sure you could recognize that there's an issue with this person's middle finger. They can also experience gangrene of the digits and ulceration of the affected digits. Let's move on to small vessel vasculitis. You recognize this. Wecke Cianca ner granulomatous is a necrotizing granulomatous vasculitis that affects the kidneys, lungs, and nasopharynx. Oh, and guess what? The eyes, possibly. Wegener granulomatosis is a middle-aged man lesion issue problem that shows up with sinusitis, nasopharyngeal ulcer, hemoptysis, coughing up blood and whatnot, bilateral nodular lung infiltrates, blood in the urine, and glomerulonephritis. C. ANCA associated with Wegener granulomatosis, right? Wegener granulomatosis disease activity is correlated with serum C. ANCA concentrations. When the pathologist reviews the histology of Wegener granulomatosis, they will see vessels affected by necrotizing granulomas and nearby necrotizing vasculitis. Wegener granulomatosis is treated with cyclophosphamide and steroids. Relapses are common for Wegener granulomatosis. Here we have an H&E section showing inflammatory infiltrate and multiple giant cells associated with granulomatosis with polyangiitis and ANCA-associated granulomatosis vasculitis. This is a biopsy from the lung. Here we have other findings associated with Wegener granulomatosis. Note that the lung is affected. And again, hammering this home. In this image, we have nasal sarcoidosis. We also have granulomatous with polyangiitis involving this tissue. We also have disruption of the wall, small mucosal vessels. And we also have non-infectious inflammatory lesions of the sinonasal tract. This all hints towards pathology supporting a diagnosis of Wegener granulomatosis. In this condition, the gums can even be affected, causing purplish red swelling of the gingiva mucosa even. Now, in this image, we're making sure that you can see the giant cells. There are even arrows pointing to them. You got this. Let's talk about microscopic polyangiitis. With microscopic polyangiitis, you will see a necrotizing vasculitis that affects mainly organs, including the kidney and lung. Although there is no nasopharyngeal involvement and no granulomas and microscopic polyangiitis, the presentation is similar to Wegener's granulomatosis. But unlike Wegener's granulomatosis, P-ANCA signifies microscopic polyangiitis, right? Wegener granulomatosis has C-ANCA, and microscopic polyangiitis disease activity is correlated with serum levels of P-ANCA. Microscopic polyangiitis is treated by corticosteroids and cyclophosphamide. Microscopic polyangiitis is prone to relapses. Here we have an ultra-wide field fluorescent angiography of a patient with microscopic polyangiitis showing mild peripheral late leakage of the left eye. Look at those arrows. Let's talk about Church-Strauss syndrome, okay? We've seen this image, right? In Church-Strauss syndrome, multiple organs are affected by a necrotizing granulomatous inflammation with eosinophils, right? Those bilobed pink guys. Granulomatous inflammation with eosinophils. And what organs are particularly affected by Church-Strauss syndrome? Well, the heart and the lungs. Church-Strauss syndrome is associated with peripheral eosinophilia and asthma. Church-Strauss syndrome disease activity is correlated with serum P-ANCA concentrations, okay? Remember that. Here we have a depiction of findings associated with Church-Strauss syndrome. It affects the lung and is associated with eosinophils, right? Let's talk about Henoch-Schloelen purpura, HSP. Henoch-Schloelen purpura is a vasculitis caused by the deposition of IgA. Henoch-Schloelen purpura, IgA, immune complexes. And you could see that on direct immunofluorescence, right? They utilize this in pathology with their fancy microscopes. Some of them need to be in a dark room to do direct immunofluorescence. If you get the opportunity to ever see this, you should check it out. Henoch-Schloelen purpura is the most common vasculitis in the pediatric population. Symptoms of Henoch-Schloelen purpura include hematuria, gastrointestinal pain, bleeding, and a characteristic rash described as, buzzword, palpable purpura on the buttocks and legs. Henoch-Schloelen purpura happens frequently after an upper respiratory tract infection. Henoch-Schloelen purpura illness is a self-limited condition, but may return. If severe, Henoch-Schloelen purpura is treated with corticosteroids. And with that, we'll wrap up. Wow, you know so much. You know about C-ANCA, you know about P-ANCA, you know about all the vasculitides of importance that are high test fodder. You're going to do so good. Step 1, pass, fail. You're going to do so great. All this information is serving as a foundation for you to excel in whatever residency program that you're going into. I'm proud of you. Keep up the good work, and we'll chat later.